As you can see from this slide, a slide that's become familiar for those that have taken the time to watch these presentations, this slide represents the total number of tests and the positivity rate here in the state of California. Again, positivity rate is the number of people, the percentage of people that tested positive that were tested in the state. The first 14 days, and the two numbers you see on the slide, 40.8% and 5.1%, represent the first 14-day cohort of positivity. Again, most of the people in the beginning of this pandemic that went to seek testing were symptomatic, so it's not surprising those numbers in the beginning of this pandemic were so high. The blue bar you see represented on the slide are the total number of tests. So we have significantly increased the ramp of testing, and you've seen a significant decrease in the positivity rate. But I reminded you yesterday, I'll remind you again today, point of caution. The positivity rate has begun to increase over the course of the last few weeks. It's 5.1% now positivity rate over the last 14 days. What I'm not sharing in terms of a slide, but want to share with you in a transparent way, is a 5.6% positivity rate in the last 7 days. So this slide represents the last 14 days, but the positivity rate is north of the 5.1%, again, 5.6% in the last 7 days. Total number of cases, yesterday we had a record high, 7,149 people that tested positive for COVID-19. You'll see today that number dropped to 5,349, still higher than we would like it to be, still a point of concern. Yesterday, we tested a record number of people. Over 101,000 people were tested in the state of California. Now north of 3.7 million, roughly 3.7 million people have been tested since the beginning of this pandemic. We've averaged over the last 7 days 88,000 tests in the state of California. While that is significant, it's not where we need to be. We need to continue to increase our testing, continue to increase our community, what we refer to as surveillance, so we can get a better handle of the total number of positive cases and understand the nuances between those with symptoms, those that are asymptomatic without symptoms, and those that are pre-symptomatic. But these case numbers, when you get a look over the course of the last few weeks, we are seeing roughly 56,000 new cases just in the last 14 days, and so points of obvious and real concern. Accordingly, we mark, as we've made this point on multiple occasions, consideration above all else to the total number of hospitalizations as it relates to people that are coming into our hospitals that test positive for COVID-19. Yesterday, I shared a slide with you that showed 29% increase in hospitalizations over a 14-day period. You could see from this slide, it's increased slightly to 32% increase in total hospitalizations over the last 14 days. We now have 4,240 individuals that are hospitalized as COVID-19 patients. Yesterday we shared, and I'll share it again today, a pie chart of the total surge capacity within our hospital system. This is an incredibly important chart, and this marks the efforts that we have advanced over the course of the last number of months, not just, again, to sit on our hands, but to address your anxiety and the legitimate concern we had to prepare for an increase in total hospitalizations. As you can see from this chart, some 52,745 surge beds have been identified that we can make available to meet the needs if capacity within our existing hospital system becomes stretched with COVID-19 patients. Like yesterday, today, roughly 8% of that capacity has now been absorbed. 8% of that capacity in terms of total hospitalization system capacity within our surge plan has been absorbed based upon the total number of positive patients in our hospitals. By the way, that hospitalization number represents a 3.5% increase compared to our previous reporting period yesterday. We look at ICU numbers, and indeed ICU numbers, not dissimilar to yesterday, are increasing. You'll see a 19% increase in this chart of ICU admissions over the last 14-day period. Yesterday it was 18%. So we're seeing a slight increase, 3% increase over yesterday, but over a 14-day period represents a 19% increase, 1,306 individuals within our total population of patients in our ICUs. This, represented on this pie chart, is roughly 34% of the available ICU beds within our system. If you compare this chart to the one I put out yesterday, we were roughly 29% or so of our capacity, or rather, excuse me, 31% of our capacity, forgive me, roughly in the ballpark, a few percentage points higher today in terms of that blue part of this pie in terms of the total capacity for two reasons. One, the increase in the number of ICU patients, but also a decrease in the total number, the universe of available ICU beds. Remember, that number changes day to day based upon the entire hospital system and the availability of ICUs for patients that come into the ICUs for multiple different reasons. Again, 8% on the hospitalizations of capacity, about 34% as it relates to ICU capacity in the aggregate for the state of California. And I'll remind you, as I always do, we do not live in the aggregate. And so these conditions are different. These percentages are different by county. And we encourage you, and I'll say this on multiple occasions in the presentation today, encourage you to go to the covid19.ca.gov website, covid19.ca.gov website, to take a look county by county at what is available, looking at those attestation plans, which are the preparedness plans put up by your county health officials in concurrence with your county representatives that attest to certain criteria and conditions before they can move further in to the reopening of their economy into these phases as they've been referred to. So that's an update in terms of the daily totals. I want to, though, go back and take advantage a little bit of your time today and talk about modeling. It can be a head scratcher, to be candid, going back months, watching all these charts on the evening news and cable networks, people debating the methodology of these different models, people using the University of Washington models, maybe those using Johns Hopkins models, California using the UCLA models, or the MIT models, or the RAND models, or I can continue down this path. Many different models are put up, charts and graphs, waves, dots, and if you're like me, they can become profoundly confusing. And so today, I want to simplify what often you are presented, what you may look at and have your eyes roll, try to make some sense of it, and also to provide a framework in a moment where more people can participate in the modeling and avail themselves of their expertise to the collective effort here in the state of California, and we would argue across the rest of the nation, in improving our modeling capacity, making it more real-time, making it, more important than anything else, relevant in your lives. But the purpose of this model is to make 2 points. One is these models guide actions. They're not determinative of our future. You've heard me on multiple occasions make this point. The future is not just something to experience. We are not victims of fate. We can manifest the future. It's not something in front of us, it's something inside of us. I say this often, it's decisions, not conditions, that determine our fate and future. In the state of California, we are proof of that. You see this, one of the original models that was put out many, many months ago, very simple model that talked about no intervention, meaning you just rolled out of bed. We all just went along with whatever was thrown at us. And without any intervention, the expectation and the reality, as you've experienced in some states, that there would be a large surge or a significant increase in the surge of transmissions of the virus, and as a consequence, a big impact on the hospital care delivery system, on the healthcare delivery system. Interventions, what we refer to in technical terms as non-pharmaceutical interventions like stay-at-home orders, practicing social distancing, physical distancing, wearing a face mask, allowed us to prepare, protect, and promote, as we put on this slide, a different outcome. And as a consequence, because of the interventions here in the state of California, we were able to mitigate that curve, and we never experienced that sharp increase. But what we did do is we pushed out, because of these innovations, the growth of that curve, but more modestly, so that we had time to develop more capacity in our hospital system, more capacity to provide the protective gear that has become so important in terms of reopening our economy, and moreover, making sure that when people are in need of support and help, that we are there to provide it in a proactive, comprehensive, and thoughtful way. What we are doing today is not only trying to explain a little bit more about the modeling. Dr. Galley is going to come up here in a moment to do just that. But we want to open up the opportunity for more and more people to get engaged in helping us build our models, what we refer to in this slide as a model of models. You'll see that we currently have on our covid19.ca.gov website, and I encourage you to take a look at this site, and you'll see specifically, if you want to just go directly to the slide that I'm referring, go to CalCat, C-A-L-C-A-T, covid19.ca.gov. But this CalCat allows you the tool to get access to our models, these nowcast models, these forecast models, and then these larger models that run, frankly, just scenarios of planning. Dr. Galley is going to come up in a moment and explain a little bit of what forecast versus nowcast modeling means and how we've stacked all of these different models that I referenced just a moment ago together, and we've made them available on this site. But what we want to do today is something much more robust and significant, and that is we want to open up our site to netizens, as it's often referred to, of citizen scientists, people that are out there doing coding every single day. We want to give them access through an open source platform to all of the available data that we have, that I have, that our health professionals have, in a way that we don't believe has been done anywhere else in the United States. This is a deep dive for transparency and openness. This is a new resource that we're making available today. This open source resource is available at github.com/gov. You'll see at State of California, you'll see it on the screen there. We're making available the capacity for people to participate and help build our modeling capacity. Because one thing we recognize is the limitlessness of the capacity of expertise and talent that resides throughout the state of California, throughout the United States, and for that matter, throughout the rest of the world. The information that we're now making available is exactly the information we make available to county health officials. It's the information that guides the incredible work that Mike Wilkenine and DJ Patel have been doing on our team, these data expertise, the data expertise that they provide, second to none. It's the kind of work that they do every single day, where now we're opening up to all of you. We're opening up to mathematicians. We're opening up to people that are experts in AI, and opening up to our researchers and our scientists and our Nobel laureates and our partners across the spectrum, including, again, citizens that just have an expertise that hasn't been tapped, they haven't been asked, or they haven't availed themselves to the opportunity to engage. This goes beyond flat files, goes beyond, forgive me, APIs and these simple protocols. We're doing something much more dynamic, something much more interactive, something that could truly bring to life a visualization of this data in a much more timely way. It's rather simple. We want to make the modeling more purposeful. We want to make it more efficacious. We want to make it more meaningful. We want it to promote a different outcome by promoting a different consciousness and ultimately promoting a different behavior. And, dare I say this, we want to back up the health professionals, because this is the data they use that guide their decision-making. And often that decision-making is questioned by pundits, some for good reasons, some for more mischievous reasons, more of an ideological argument or frame. We want to put all this out there, and we want it tested, and we want it challenged. And we recognize there's the reason this is not always done is it will be tested and it will be challenged. And I think you deserve that, and I think we have a responsibility to advance that paradigm, that value, and that protocol. It's all about collaboration. It's all about engaging expertise. And as I say many, many occasions, expertise can be found anywhere and everywhere, given the opportunity. And I think we've now afforded that opportunity. I think we're going to see some really dynamic and exciting things come from these new protocols and this new opportunity to engage in these new tools and ultimately help us engage in making protocols and process that help inform our guidelines and protocols and procedures, but more importantly, to encourage better individual behavior to back up the assertions that many are making about the critical nature of wearing face masks and continuing the social distancing and physical distancing required at this moment. Let me no longer belabor this. Let me now ask Dr. Galley to come up and make a little bit more sense of what these models may do, what they mean for you, for our decision making, and again, how all of you can participate now in helping us inform our next steps in this pandemic. Dr. Galley?